listening to On the Couch with Carly. Carly's couch is a safe space to talk. I'm a psychologist, but I'm not your pipe-smoking, tweed-wearing stereotype.
Hello, and welcome back to On the Couch with Carly. I'm going to do another driving podcast because I'm a busy mom who doesn't have time to do the things I need to do. So I am going to try and multitask and do a little podcast while I go to work. So today I felt like having a little chat about diagnosis. The thing about being a psychologist and you know, I am a clinical psychologist, which is a particular branch of psychology, is that I have got more sort of medical training than, say, a counselor or a coach, a therapist. Anyone that isn't a psychologist, clinical psychologist, doesn't have the same amount of training that I have. And the main difference of, you know, where my training has been, what it's been steeped in, has been the medical model. So when we did our training, we worked alongside psychiatrists, and obviously people get very confused about the difference between what a psychologist and a psychiatrist is. A psychologist is a person whose interest is in the person's sort of psychological distress, and therefore the treatment is mostly around psychological symptoms, and we do talk therapy as an intervention, and some psychologists will do behavioral interventions, whereas a psychiatrist is a medical doctor who has already studied medicine and then goes on to specialize, like you would specialize in orthopedics or you would specialize in pediatrics. The psychiatrist specializes in the psychiatry. And so they have advanced medical knowledge on psychiatric conditions. And really what they do is they prescribe medication. That's their main form of treatment and intervention. So they are very well versed in understanding the different drugs that are on the market and how those interact with different psychiatric conditions. And often psychologists and psychiatrists work together to treat a patient, because most particularly severe psychiatric conditions require both medicine and psychology therapy, talk therapy, in order to help the patient manage their symptoms. So I wanted to talk today about diagnosis and why, what is the meaning of diagnosis for me? Why do we diagnose? What is the benefit of diagnosing? What are some of the pitfalls of diagnosing? Because I think lay people, you guys, don't really understand all too well why we diagnose. And also every individual clinician has a different take on this. And I think that's also really important, is to clarify what my particular take is, because it's unique to me and I use it. Also just trying to get my camera not looking like that. It's unique to me and I use it in my own way in my practice. So when I was trained, we learned about the DSM, which is like the main diagnostic manual, which is from the American Psychiatric Association. And the DSM is like the Bible for psychiatrists, for people working in psychiatrics, because it divides the psychiatric population, the clinical population, into discrete categories. You are either schizophrenic, or you are bipolar, or you are depressed, and each individual will have a particular diagnosis. So there's many different kinds of depression diagnoses. There's many different kinds of anxiety diagnoses. And you've got to know, based on what your client or your patient is exhibiting in terms of their symptoms, you've got to know how to classify them according to this system of classification. And it's useful for many reasons. One of the reasons it's useful is that it is a common language for clinicians to use. So it means that you can communicate with other professionals and you have a shared understanding of what you're saying about this patient by using these diagnostic criteria. It's also useful in terms of creating a standardization so that these disorders can be studied and we can work out which treatments are effective, because if we can see that the treatment is reducing symptoms along the lines of that diagnostic criteria. So let's say to have a depressive diagnosis, you need to have lethargy, you need to have low mood, you need to have feelings of sadness, you need to have sleep disturbance, appetite disturbance. Those are some of the symptoms. Now, if I want to test an intervention to see whether a medicine or whether a therapy actually works, actually treats the symptoms of the depression, then I can use those diagnostic criteria to work out, has this person, is this person no longer depressed? Do they no longer meet the criteria, or have the symptoms reduced? They haven't worsened, they've gotten better. So all of that is useful in sort of working out treatment programs. So I do believe in the DSM. I do believe that it's useful. It has got its pitfalls, and that is that it is a classification system, and classification systems are inherently biased. So how are we determining what disorders are? How we're determining the categories, that them falling into discrete categories? Like, how do we decide that this is depression and this isn't? How we who's coming up with these theories, right? Who's naming them? Where are the studies being done? What is the client population or the patient population that's being used as a sample to determine how we understand these? All of this has inherent bias. And what I mean by that is mostly we are looking at science and theory that is coming out of Western countries. Predominantly it's American and then to a lesser degree European studies that are being done, clinicians' ideas that are being used, client population, samples, etc. And so what that means is that we just have to be aware that the way it's written, the way it's spoken about, the way it's classified is from a specific context, but it is speaking as if it is absolutely generalizable to absolutely everyone in the world. And that is a bias, right? Like, we don't know if that's the case. We don't know if every single nation in the world can be classified in the same way that America can be classified or American citizens can be classified. That's not necessarily true. That is a kind of a biased idea. So we just have to be aware of that. We know that, for example, in South Africa, where we have such a diverse array of cultures and, different language groups and, people have different cultural practices within their cultures. We know that there are certain ways in which the DSM fails our client population because they don't understand certain symptoms within the cultural context. So, for example, we know that if, according to the DSM, if you're hearing voices, that is a sign of psychosis. Psychosis could mean any number. Psychosis is a symptom of many other disorders, including schizophrenia, bipolar with psychotic symptoms, etc. Schizotypal disorder. Now, we also know that in South Africa, hearing voices has cultural significance to certain cultural groups. So certain people will hear voices and it will not be because they have a psychiatric condition that needs to be treated. They are, in actual fact, sangomas. They're people that are that provide traditional medicine. So we need to just be aware of things like that. And, that just means that as a clinician, as an individual clinician, you look at that so-called Bible, the textbook of the DSM, and you think, okay, this is a framework and I must use what is useful about it, and I must leave the rest. And so what is useful about having a diagnostic manual, and what is useful about having a classification system, and what is useful about giving a diagnosis to a patient? Why would it matter if someone comes to me and tells me about their lives, tells me what's happening, and then I say to them, I think you're depressed? What is the benefit of that? And I think there's many different reasons for that. So on the one hand, I do think that for some people, it's very meaningful to have someone say, what you're experiencing is not just you being difficult. For example, a lot of people come to my practice, particularly women actually, and they've been told they're just too sensitive. They're just too emotional. They just get upset about things they shouldn't be getting upset about. And a lot of families find it very inconvenient when people are sensitive and when people get upset and when people struggle with difficulties. And then the client will tell me, this happened and this happened and this happened. And then I was upset and my family found it very, very inconvenient or frustrating. And then I'm, reframing it for them and saying, well, your boundaries were violated. You were mistreated. That is cruel treatment. That was unfair on you. You were only a child. You shouldn't have been expected to tolerate that level of distress. And it's very normalizing. It comes as a relief for people who have been told their whole lives to not be so sensitive, to harden up, to just take it on the chin. It comes as a super relief to hear someone say, actually, what you've experienced is really hard, and it's okay that it feels really hard, and it's okay that you are struggling to manage it. So on the one hand, there is a part of this that is about normalizing and acknowledging for people, validating for people that there's something going on here and it is actually really hard. And that is to say that, we know that psychiatric conditions, and this is, my kind of thing that I have about the DSM. It's like we know that the way we classify human beings is imperfect. It's imperfect. We don't have all the answers. We don't know if we are 100% sure that someone who has this diagnosis doesn't also have something else, or that if they have these symptoms, that they definitely have this diagnosis and not, calling it something else. For example, a person who has lost their partner and is grieving, what is the period of time that you're supposed to grieve in? And when does it go beyond that and into the realm of depression? Now, the DSM has a rule about that. They say that you have to be, you have to have a cutoff time. And if you are still sad and you're still not getting out of bed and you're still not managing to keep up with your daily activities and you're not functioning in your life after a certain period, then it's depression. It's not bereavement anymore. But that is something that feels like it's maybe a bit of a random marker, and maybe it's not random. I mean, I know that the DSM is rigorously tested, but what if for some people grief? So is there meaning then for me to say to you, actually, I think this is depression. This has gone beyond what is grief, what is normal grief. I don't know. I'm not sure about that. You have to take it client by client, kind of individual by individual. What would be meaningful to them? Do they just need to hear that it's okay that grief is taking long, that this is really hard, that or do some people really feel comforted by hearing that actually this is not supposed to feel like this? And even if it is supposed to feel like this, like even, let's say you just had a baby, and I work a lot with new moms. You just had a baby, you're feeling overwhelmed, anxious, sad, it's stressful. To a degree, that is normal, right? That is a normal response to an overwhelming situation. And if you are coming to me because your quality of life is significantly reduced by the fact that you're having these symptoms, and even though there might be a million reasons other than the fact that there's something wrong with you, that you're having this experience. It might be a lack of support, a lack of provision. You might just be, stressed because there's other life events happening around you that are stressing you out. It might be a temporary thing to do with brain chemistry because of hormonal levels. But if you are struggling, and it makes sense for us to say to you, actually, you don't need to struggle. You don't have to live like this. And by calling it depression, or anxiety, an anxiety disorder, we get to actually treat you. We get to actually say, you deserve treatment. You deserve to have someone alleviate these symptoms with you. I think that's meaningful. And so I try and stay away from these binaries that we get set up as like, Is diagnosis real? Are we really depressed? Or is it something else? Are we just struggling to accommodate to normal life events? Do we actually need a diagnosis? Is diagnosing someone pathologizing someone when in actual fact they're just a normal person dealing with hard life events? That's another question that's interesting with diagnosis, because some people don't actually benefit from being diagnosed. And I think this is something that we need to be particularly aware of when it comes to children and young people, which is, what are we doing when we diagnose a child early on? Okay, look, there are some kids that are just fully, obviously struggling and need a diagnosis. And maybe we need to think about having the diagnosis being something for the clinician's benefit, for the parent's benefit, but maybe not to give to the child. And there are some patients who I will not share their diagnoses with them necessarily. I mean, if they ask me, I would, but it's not something I would lead with in my therapy with them, because it's not meaningful to them, or in my mind, for them to have the diagnosis, because it's pathologizing. With children, to get a diagnosis and to be told there's something wrong with you and we have to fix it is a very, very, you've got to really be thinking hard about whether that's useful for the child, or whether that can have long-lasting impact on how the child feels about themselves, how they manage with life stresses going forward. You want people to feel like they are equipped to handle their difficulties, and not that the diagnosis indicates that they have a weakness in them, or that they are particularly broken, or that they have something wrong with them. So I really believe in diagnosis for certain reasons. I don't believe that every person benefits from having a diagnosis. For the most part, when I work with people and I give them a diagnosis, it comes as a relief. It feels like there's this thing that I've had to be dealing with my whole life. And I thought it was just because I had a personality defect. I thought it was just because I just didn't know how to do things like other people did. And when I get that diagnosis, it suddenly all makes sense that, oh no, I am not the problem. There is a problem that is like, there's a problem, and that problem visits me. And when it visits me, then I have to deal with it, And that's called externalizing the problem. And it's a really useful technique to help people realize that when I'm depressed, it's not because I'm failing. When I'm depressed, it's because I have an illness, and that illness needs to be sorted out. And so the language you use when you talk about diagnosis is really important with your clients, to say to someone, you are not the problem. You don't need to be fixed. You are not broken. You have an illness. If you had another kind of illness that had physical symptoms, or only physical symptoms, because often psychiatric conditions also have physical symptoms. But if you had a physical illness that only had physical symptoms, you would be fine getting treatment for those physical symptoms. You wouldn't feel like it was a moral failing. And I think this is the problem with psychology, is that we have a history of equating psychology with morality. We have a history in psychology of putting people in asylums, of making them feel like being mad is the equivalent of being bad, and they deserve to be imprisoned because they're deviants. And that is something psychology has to be responsible for. We have actually done that in the past. We've moved far away from that in recent years, but that doesn't mean that there isn't a lingering question around that in our society. People still are nervous to see a psychologist, or to speak to someone, or to get a psychiatric diagnosis, because it feels like a label that is and morally questionable, right? Like that you've done something bad, that you're not good. And we really want to move away from that. One of the interesting diagnoses that we're seeing a lot of at the moment, and I'm sure for those of you who are on social media, you are aware that it's everywhere on social media as well. And that is ADHD, adult ADHD, getting diagnosed with adult ADHD late in life. It's happening to a lot of women at the moment. And I think it's a really interesting diagnosis, because it's kind of picking up on all the points I just made. It's a diagnosis that a lot of boys were getting when they were little, So as young boys, they were getting told they're ADHD. And the reason why boys were being picked up more than girls is that in boys, it manifests very clearly in physical behaviors. So boys are literally bouncing off walls, climbing, jumping, physically very agitated, physically very hyperactive. And it was very difficult for the teachers to manage that, because in a classroom environment, children who are very mobile and hyperactive and who are physically very distracting with their bodies in class causes problems for everyone in that learning environment. Whereas we're now knowing that girl children who didn't get diagnosed 30, 40 years ago, or whatever it may be, were also experiencing ADHD symptoms, but where the boys were manifesting it physically, the girls were manifesting it much more internally. And girls are much more likely to have a very hyperactive mind. And I think that's really, really fascinating and speaks to people's lived experience. And I think that's something that's so important when it comes to diagnosis is, does having the diagnosis, does hearing about how the diagnosis has come to be and how we classify people with a certain diagnosis, does that resonate with someone's lived experience? And when it does, it's meaningful. We really need to recognize that actually then it doesn't really matter whether the research was done with your client population or not, whether you can generalize those results. If your client is sitting in front of you and saying, that feels like they're talking about my lived experience, it can be so, so meaningful for someone. And, a lot of women get very, very emotional when they hear the information that is now coming about around ADHD, because it's a lot of people have lived with this and lived with these symptoms and felt very alone in these symptoms. And it's an awful experience to have an experience inside of your mind, because no one can see inside of your mind. No one can know what it feels like, the way you are talking to yourself internally, the way your internal dialogue sounds, but also how that internal dialogue then stimulates your emotional system, your somatic system. So your body is responding to what's happening inside of you, and no one can really see that. They can often see the reaction to that. They can see, whether if you might be tearful, you might seem very anxious, you might seem very stressed, you might seem like someone who's always, dropping the balls in life, like, got tasks that don't get complete, and that can be very frustrating. But no one can see why that happens, right? Why do those symptoms manifest? And for a person who's having that experience in themselves, it's very isolating, it's very lonely to be having an experience that no one really gets insight into or sees or understands. So then they hear someone discussing the ins and outs of ADHD, for example, and it feels like it's an incredibly cathartic moment of relief when it suddenly is like, oh my gosh, I'm not alone. Someone has insight into this. Someone knows what it feels like. Someone is painting the picture and putting, filling in the lines here, painting the kind of dot to dot, working out, okay, this is actually what I'm going through. And it's for a reason. There's a reason. And the reason is that my brain is like other people's brains, and it's different in ways that can be mapped. I think that's so important, because sometimes we feel different, but we feel like we're the kind of different that no one's like us. There's nothing like, no one else experiences my brain. And I think that's really hard. But when we can say, look, your brain works differently, but it works the same as all these other people, and they're all feeling the way you feel, I think that's so helpful. People just feel so comforted by that idea. And so I love working with people who take comfort from diagnoses and then use that information to actually have compassion for themselves. And this is a big one for me. This is the major reason why I would say diagnosis is useful. Is that if I can diagnose you And that actually leads to further self-compassion. If that means that you are now walking around the world and you're actually giving yourself a break. Now, a lot of people say, oh, but it's just, they're just going to use it as an excuse. Now people have this diagnosis. Now they can just carry on with their bullshit and use it as an excuse. Oh, I'm ADHD, therefore I can't do this. Oh, I'm ADHD, therefore I can't show up on time. Oh, I'm ADHD, therefore I can't hand in my assignment. No, I'm not saying that that's the use of diagnosis. And I think that, we need to give people the benefit of the doubt. There are definitely going to be personalities that take psychological concepts and use them to their advantage. It is just, unfortunately, a reality that certain personality types, certain traits people with those traits are going to make use of psychological language to their benefit. They're going to use it manipulatively. They're going to use it to not take accountability for their behavior. They're going to use it to excuse bad behavior. And I think that we have to accept that that's going to happen. But that is not the majority. It's just not. The majority of ADHD women in my practice are not going around the world being like, cool, I'm just going to be an asshole and now I'm just going to tell everyone it's because I've got ADHD. That is just not happening. If anything, it's about having self-compassion and having just another way of talking to yourself about the things that you struggle with that maybe comes from a place of understanding, comes from a place of there is a collective meaning making to be done here. This is not something I have to do on my own. I'm not alone. And I can really understand myself and actually stop pathologizing myself, stop calling myself names, stop treating myself like I'm just like useless and I can't get things done, but actually really understanding the processes behind that. And most importantly, for me in my work, if you know what your diagnosis is and you know how your brain works differently and you know what you struggle with, then we can look at how do we scaffold you? How do we manage these symptoms? How are we creating systems and structures and programs in your life to assist you to manage better? Because what's the point of having a diagnosis if we don't then use that to inform our treatment plan? That's the only reason to have a diagnosis, right? Is to then say, cool, we know what you're struggling with, but this is how we're going to help you with it, right? Like it's obvious. That's the point. So that's really why I'm always quite careful when people come to me with diagnoses and start to say to me things like, I knew I was messed up and now I have a label for it, No. We want to steer away from pathologizing. We want to steer away from labeling and stigmatizing. We want to be using diagnoses as a way of informing our treatment and encouraging and increasing compassion and empathy. I hope you enjoyed this one. Thanks so much for listening. Bye.
Thank you so much for listening to On the Couch with Carly. If something in this episode resonated with you or made you feel less alone, that means the world to me. You can find us on Apple Podcasts, Spotify, and now in video format on YouTube. For exclusive content and resources, visit our website at onthecouchwithcarly.com. If you enjoyed today's conversation, please consider leaving a rating or review. It really does help others discover our safe space for authentic conversation. Until next time, please take good care of yourself. I can't wait to be back on the couch with you again.